Hello, everyone. We're going to wait just another minute to allow for some late arrivals. Thank you so much for being on time. Thank you, everyone. We're going to wait just another minute to allow for some late arrivals. Thank you. Okay, hello everybody. I am Dr. Diane. Welcome to the RSC Lunch and Learn. We are excited to see you here. We are welcoming today our Professor Remington Harris, who has served as a legislative aide in the Florida House of Representatives and was involved in the passage of the Window of Opportunity Act. This legislation provided insurance coverage for therapies to benefit children diagnosed with autism spectrum disorder. Professor Harris is a U.S. Army veteran. After completing his active duty military obligations, he has continued military service in the U.S. Army Reserve component as a psychological operator with the rank of major. Thank you for your service. He currently provides therapy to children with ASD at Skyrocket Behavioral Services. He also teaches Intro to Psych and Lifespan Development here at Keiser on the Fort Lauderdale campus. And we are excited to have you join us to present what barriers prevent post 9/11 active duty Army combat veterans from completing individual talk therapy, a qualitative study. All right, you can take it away.
Thank you, Doctor, for that kind introduction. I know that my title is a mouthful. You nailed it. So thank you for that. And thank you for all joining me on your lunch hour. I appreciate that. But before I get started, I wanted to give some additional context behind this PowerPoint. It was put together after the results of my dissertation, which took about 2 years. I did a qualitative study, as you can see, gathered a lot of data, interpreted the data, coded the data with myself and the help of my dissertation chair. Her name's Dr. Bobova. Dr. Bobova is a professor at Adler University in Chicago, and she specializes in psychological sciences, including statistics and research methods. She's also the associate chair of the Department of Clinical Psychology at Adler University, so I was very fortunate that she agreed to also serve as my dissertation chair. Yes. On this slide, you see the research question, and it's also the title of my research, and that was done intentionally. In doing research, qualitative research, I was taught that the researcher should pose a broad question, a broad research question that helps them focus their efforts. And I found this to be very helpful to me because it's a long endeavor. Like I said, it almost took me 2 years to complete. And one can easily get lost in the literature because there's so much out there that's related or adjacent to one's research ideas. So my dissertation was designed to basically listen and learn from the research participants, and we'll go over inclusion criteria here in a moment. But in a nutshell, I just wanted to listen and learn from my research participants. I wanted to honor their voices, and I wanted to integrate their views within the scientific literature. And specifically, I was interested in listening to their answers related to my research question. So in other words, I just wanted to learn from them how we as clinicians could do better when delivering these psychological services that we provide in psychotherapy. Um, and really, before you get into research, any curious person, when you want to answer a question, in research, you really have to first do a comprehensive review of the existing literature that's out there right now, because there might already be answers to the question that you're posing. And if there's not, um, if your research question is not already out there in the existing literature, that's sort of exciting. That's sort of new uh, territory, if you will, in the landscape of the literature. And if there's nothing per se that's out there that you can replicate, you should then look for adjacent research, and that's what I did. And I found that the literature in military psychology was really filled with studies that were dedicated to finding the most effective evidence-based treatment for PTSD. Um, so the researchers, they were doing a lot of quantitative research out there, and their question was, what is the most effective and evidence-based treatment for PTSD? And what I saw in the overall landscape of the literature was sort of a fixation, at least from my perspective, on PTSD. And I think, unfortunately, not just to blame the researchers, but I think we live in a time where PTSD and the American veteran are sort of they're synonyms, they're synonymous. The two ideas are sort of fused as one. When you think of veteran, and I'm a veteran and I'm guilty of this too, you think they probably have PTSD. But that's not necessarily the case. In fact, a small minority of combat veterans even uh, currently meets the diagnostic criteria for PTSD. I've read in the research, and it ranges, and it's probably somewhat underreported, but anywhere between 18 and 22% of current combat veterans or veterans meet the diagnostic criteria for PTSD. So I thought this sort of fixation on PTSD um, was a noble endeavor, but I think it's now time that we move on to other topics of interest out there that are affecting our nation's fighting forces. Um, and I'm going to go over the results later on. It's basically just the answers that I was given from the research participants. Here's sort of an outline of my dissertation. It was 6 chapters. This is not the only way to do it, but this is a way to do it, and it's very common to sort of outline what you're really writing about. And I find anything in writing, the first thing that I like to do is I like to outline my table of contents. And that just really gives me the skeleton of what I'm really trying to write. And then I apply, the flesh, if you will, as time goes on. But in my introduction, you can see the subheadings. I just wanted to basically give the background of the problem, why I wanted to do the study, what the significance of the study was, the purpose of the study, and so forth. In chapter 2, simply entitled Literature Review, that's just sort of what I walked you through just on the previous slide. I wanted to do a real deep dive into the existing literature right now, and I sort of just outlined sort of what I found. And that was this sort of myopic research question, at least from my view, that was out there, and it was simply just dedicated to finding the best EBT, or the best evidence-based treatment for PTSD. And by the way, after all the millions of dollars that were spent on these studies, I would say that the jury is still out. I don't think we still know the answer to that question. And anytime you're dealing in social sciences with human beings, we're very complex, and there's probably a lot of variability as to what the most effective EBT is out there. In chapter 3, methodology, again, you can see there's a lot of subheadings under chapter 3, and it's a little bit more technical, not for you all, the audience here, but if there's any students out there, I'd be more than happy to take any questions on the more technical aspects of my methodology. And Chapter 4 was results. These are just the answers that I collected from my research participants. And in chapter 5, I did a short conclusion and some recommendations based upon the answers that I collected. And the final chapter, chapter 6, it's not a mandatory chapter that you have to do if you're doing your own dissertation or your own research project. But I believe that good qualitative researchers will divulge in an effort to be transparent their own assumptions that they make, their own blind spots, limitations, biases, and we all have these as human beings, and there's nothing wrong with that. So the best that we can do, I think, is to really just throw these out there and be truthful after conducting a lot of introspection and just to lay it out for the reader and say, these are some assumptions that I've made. Here's some limitations to the study. I didn't get to this part, or this population, for example. Um, Maybe for future studies, um, you know, somebody else will carry the torch, if you will, and replicate the study within the Air Force. My research participants were only in the Army. That's just one example of sort of disclosing these limitations of the study. All right, so I talked briefly about inclusion criteria. There was 5 criteria that I was looking for. And I did a pre-screening survey. I blasted it out via different social media platforms, and I was looking for these 5 things. So the first has to do with the branch of service, which is the United States Army. So I really wasn't looking for airmen or women, people in the Air Force, people in the Navy, people in the Space Force. The Space Force, when I was doing this, was actually still being stood up. Um, so I had to choose a branch, and I can go into why I did that. But all the branches of the military have their own culture, and I was sort of interested because I'm an Army veteran in the Army culture. And there's going to be different clinical implications in the Army that may look different in the Navy, and I'll speak more on that later. Um, but the first one was they had to be in the Army. They had to be combat veterans in a post 9/11 era, um, and they had to be involved in, which is part of the global war on terrorism. So the global war on terrorism started after the attacks of September 11th. George W. Bush declared a global war, and the 2 most commonly understood or known fronts were in Afghanistan, firstly, and then in Iraq. Um, but it really was a global war. We conducted military operations all across the world, in the Philippines, in South America, in the continent of Africa, other parts of the Middle East, including Syria and Iran, where we conducted covert cyber attacks against nuclear facilities in Iran. So it was very protracted. It was global, and it's our nation's longest ongoing war. It surpassed Vietnam, which took 19 years and about 6 months for us to withdraw after we had boots on the ground. And in Afghanistan alone, which is only one front in GWAT, we were there for 19 years and 11 months. But in the interest of time, I'll go through the next criteria quickly. The second one, they had to have been exposed to combat. They had to experience psychological distress secondary to their combat exposure. And they had to have sought psychotherapeutic help because of their psychological distress. And finally, they had to have had to prematurely terminated their psychological therapy sessions because of a negative internal and subjective experience, whatever that may be. And I'm studying clinical psychology, so just a quick side note. Um, I really wanted to place value on the subjective and internal experiences, or internal and unseen phenomena experienced by the research participant. But that's because I'm pursuing clinical psychology. There are other subfields in psychology. Behavioral psychologists might look at this study and say this is a little bit funny. Behavioral psychologists are more interested in observable behaviors that can be measured. Um, I wasn't really focused on that. I wasn't focused more on internal subjective phenomena. I was really trying to empower the voices of my research participants, give them the microphone, and say, how can we do better? And that was the sort of the crux of my research design. So, why do this study? Before I answer my own personal reasons for wanting to do this study, there is an old adage in research, and that is research is me search. So many researchers, including myself, are interested in explaining phenomena that they themselves have experienced. But that's only one reason to um, just pursue research. There are many other legitimate reasons to pursue a topic of interest, including a gap in information within the scientific literature. And I was sort of felt lucky or fortunate that I did view a gap in the scientific literature. And I thought that the voices of these GWOT combat veterans needed to be honored. We needed to look internally within them rather than looking at external things like what treatments are we coming up with as clinicians that we believe are most effective for them. I was sort of looking internal to the research participant and giving them a say, hey, is this working? What is not working? And so forth. But in any event, I was motivated to learn how we as clinicians can make the psychotherapy process more effective for GWOT combat veterans. Now, while I was not testing my own theory, I didn't make any big assumptions to test like the existing literature in military psychology, but I did make, of course, my own assumptions. And I would say this is more of a presumption. And this was an article that I'm showing here, written in 2021, that shows Americans um, sort of lack a basic knowledge or understanding of what the global war on terrorism was and who the GWOT combat veteran was. And I think, um, this isn't a huge leap or anything to suggest that there's this growing cultural chasm between civilian culture and military culture. And I really think that this chasm between these two cultures really started to emerge when President Richard Nixon ended the military draft, and we transitioned from the draft to an all volunteer fighting force, which is what we have today. And military veterans, me being one, I'm no exception to this rule, has really been described as a family business. So a lot of GWOT combat veterans will have their fathers, like I did, who was in the Army, and my grandfather was also in the Army. So I'm no exception to that rule. But this is an assumption that I've made, that there's this sort of growing chasm between the two cultures, and therefore clinicians, if you're a civilian with no veteran status, you're going to have a hard time understanding the cultures, the values, and the experiences of these GWOT combat veterans. So again, handing the mic over to them and saying, hey, teach us what we're missing and how can we do better, was really the point of this research. And yeah, I'd say that's enough on that. Um, so why qualitative research instead of other methods of research? Here's a few reasons that I've listed in my view why I wanted to do it in a qualitative method. However, there are some risks in conducting qualitative research, so I wanted to outline those quickly. In qualitative research, the researcher themselves, they are the instrument of measure. So if we humans are using our own senses to observe, gather, interpret, code, categorize, or otherwise make sense of the data that's being offered, we must be mindful that our own shortcoming, we must be mindful of our own shortcomings, of our own blind spots, and we must acknowledge our own assumptions, beliefs, and experiences, and even biases, and we all have these, in order to mitigate these harmful effects when interpreting the data, when coding the data, and interpreting the data after we are posing our own research questions to the research participants. So you can see that just by us simply asking a particular set of questions, we're already influencing the kind of data we're going to collect. So we will be an influence on the research data. So um, I think the best that we can do is being mindful of this so the powers of influence over the collection and interpretation of this data doesn't really poison the well, if you will. So um, while I think it's important when you're thinking about these interview questions posing to your participants, you should have sort of a script, and you should really think about, why am I asking, as a qualitative interviewer, why am I asking these questions? Why am I posing these questions to certain participants? And you should also have these questions vetted by a third party, by an objective person. But the art of qualitative interviewing, you should also um, build rapport, be human, appropriately disclose your own stuff, if that is appropriate, um, and then asking follow-up questions and being fluid. And if it takes practice, but the more you do it, the more it turns into sort of a conversation between two people. And that's really when you get the rich and nuanced qualitative data and these rich narratives that you're really wanting to collect from the person. That's really when you get into the internal phenomena that these participants experience. And again, that takes time, takes a lot of repetitions and experience. Um, but I think that's when you get the sort of the good stuff. Let's see. And I wanted to also say that when you're having these conversations with these research participants, obviously there's ethical things involved. The person has to have informed consent. They have to feel free to say pass if a question is too private or personal. Um, but we as qualitative researchers, we are really in a position of privilege, and we have to be sensitive to these very vulnerable psychological phenomena that's being disclosed to us, and being sensitive to that, obviously. Um, but if you're able to do this through the art of interviewing and really extract that lived experience from the research participant, um, that's gold, really. And to use a German word, there's a gentleman, a German, Austrian German mathematician and philosopher by the name of Edmund Ursel, and he would always use the word Erleben, which is um, it's it is the lived experience. It is the firsthand knowledge of the research participant. And this is different than the German word Verstehen, which refers to secondhand knowledge. So I, through my own filters, which are flawed, and my own schemas and my own meaning making tools that I've developed through my own lived experience, I am trying to gain at least a second hand knowledge from the research participants. But I have to, again, be aware that my own filters are flawed. My own schemas in which I am hearing their phenomena that they're sharing with me are going to be somewhat subjective. So there's things that you can do to mitigate these negative effects through these flawed filters when you're collecting the data. One of them is bracketing. So during my dissertation, I did a lot of memo writing, and I would submit these memorandums to my dissertation chair and other readers. And I would say, here's an assumption I'm making. Here's might be a bias that I have, and I would bracket them. And bracketing just means you're writing them down, you're becoming more cognizant of them, you're acknowledging them, you're giving them to the eyes of another critical reader, another critical pair of eyes. And we believe in clinical psychology, when you divulge this, it's sort of a cathartic process that um, will help me in the end honor the what the research participants are truly saying. I'm trying to really hear what they're saying, and not placing words in their mouth and not coming up with my own meaning for what they are saying. And it's sort of an unnatural thing because in conversations every day, especially in heated maybe debates or something, we're not really attending to what the other person's saying in the conversation. We're sort of thinking about our own clever quip that we're going to send back, and we're not really hearing what's being said. We might be even attending to other things in our environment, and we're distracted. So it's a hard thing to do. Listening is harder to do in qualitative research than just your daily, run-of-the-mill conversations that you're having. Um, I was also aware of, even when I was trying to um, allow somebody else to look at the information, allow them to code the information in the way they see fit, even if I was trying to do everything in my power to not influence the data, I was still going to influence the data. Um, there's just inherent qualities that we all have. My gender, for example, my gender could have influenced the answers from female participants or male participants. The voice that I have, the voice that I use, my tone, my posture, my nonverbal skills, um, these all will have an effect on the data that we're collecting. And I did all my interviews via Microsoft Teams. So I'm also aware that there might be some nonverbal information that I was not picking up because I'm not face to face with them. On the other side of that, the some of the research participants might have felt more safe divulging even more data to me because we were not sharing the same physical space. There was a digital divide that they were safe, they could hide behind. So that's just there's definitely pros and cons to the setting in which you're interviewing your research participants, but I was trying to be mindful of all these different things that would have some sort of effect on the data. All right, so here's the statement of the problem. I was assuming that premature termination is a problem. I was looking in the literature, and premature termination is a pervasive problem. Many people discontinue their psychotherapy because they have some sort of negative experience or it just wasn't helping them. And this is the problem statement that I wanted to sort of understand why this was happening. All right, so it's important too that researchers we define the terms that we're talking about. So our target audience can quite literally and figuratively be on the same page as us as researchers. So premature termination, as it relates to this study, was referring to when a patient um, they decided, I'm going to drop out. I'm not going to attend the next session because it's not really doing anything for me. Um, you know, there are other times where patients might prematurely drop out, but they attend one session, they have some sort of epiphany, and that one session was sort of life changing, and they are on the road to recovery. That does happen too, but that's not what I'm talking about. I'm talking about a negative experience internally felt by the research participant, and they said something to the effect of, "This was not for me. I'm not getting out of anything out of this, and I'm not going to attend the next session." This is a qualitative researcher, Dr. Tracy. She's from Arizona State University, and her works were influential on my dissertation. One of the things that she says that is essential of good qualitative research is timeliness. So um, I thought about timeliness, and I thought that with the recent withdrawal from Afghanistan, that uh, which for all intents and purposes, it ended the global war on terrorism. There's still some military operations and financial operations that are going on in accordance with the global war on terrorism, but with the withdrawal from Afghanistan, that pretty much ended it. So I thought, given that withdrawal, which was a historic event, timeliness was here, and this was a good time to sort of hit the reset button on the research and just allow the veterans to share their lived experiences or their firsthand accounts. So, like I said, it's the longest war. Afghanistan was um, longer than Vietnam. We were involved in the war between the North and the South Vietnamese as early as President Eisenhower in the 1950s. But really, when we think about the American involvement in the Vietnam War, it really didn't escalate until 1965 when President Johnson authorized more than 100,000 combat troops to be deployed to the South to help fight the North Vietnamese. But in Afghanistan, we were in combat in Afghanistan against the Taliban, Al Qaeda, and other groups of individuals that we deem terrorists. Uh, so, in the global war on terrorism, you can really imagine the toll that this has taken on our active duty and our reserve and our National Guard service members. I mean, they were really in the fight for almost 20 years. Um, there's also a uniqueness. I talked a little bit about these cultural chasms between civilian and military cultures, but there really is, I think, a chasm between this war and other wars that our military has fought. So, in the next few slides, I'm just going to outline a few of those unique characteristics of the GWAT combat veteran. So, historically, women have always been involved in combat in one role or another. Um, in World War II, you would see women who were serving as nurses while deployed overseas. Back at the home front, women filled more traditional male roles in factories in support of armament production and so forth. But today, with GWAT, the Global War on Terrorism, this was the first military campaign where women were allowed to serve in combat roles such as infantry, armor, and field artillery units. Um, so this was, I think, one of the biggest unique characteristics of GWAT that separated GWAT veterans from other veterans. When you think about World War II, this generation is referred to as the greatest generation. When you think about Vietnam veterans, they were called baby killers, and they were literally spit on when they returned home, and many of them were drafted because the draft was still ongoing. So each category of veteran and the wars that they fought, they're going to have different internal phenomena that they experience. And therefore, there's going to be different clinical implications, and your treatment plan for these individuals should look different as well. So the treatment plan, or the reason for doing sort of a focus on the GWAT service member, is to be able to adapt and tailor their treatment plans in a more individualized manner. Veterans, there's a lot of cultural things that we share in common, but each veteran from a different era is going to have a different, worldview on life, and uh, there's that requires a difference in treatment. Here's some more unique facets of the GWAT service member. They're more likely to be married and have a children under 5. Their deployments um, were many. They could last from 6 months to 18 months and then be redeployed back home. Uh, enjoying a period of R&R. Um, but then they might be deployed again. In World War II, our service members were sort of deployed to Europe and the East, and they were there, living there until the war was over, and then they could come home. Um, it's different. It's different in GWAT. So with the GWAT service member, the clinician that's treating the individual service member has to know that if they're married, if they have a young child who's, say, under the age of 5, and that person, that service member, was gone for, say, 18 months, that's going to affect the spouse, that's going to affect the child, and there's going to be a lot more family dynamics, statistically speaking, than previous generations of warfighters. We should also understand that with the advances of technology, with the advances of vehicles, including the mine-resistant ambush-protected vehicles, or the MRAP, that was produced and widely distributed during GWAT, more service members today are living with traumatic brain injury than ever before. So the TBI is really often referred to as the injury of the GWAT. And this is really going to take, I'll talk a little bit more about this in my recommendations, but this is really going to take a team of interprofessional um, individuals, both on the medical side and the psychological side of the house. And unfortunately, medicine and psychological services are really separated. But TBI is a physical brain injury that has a lot of psychological ramifications. You can have a change in your personality. You can be more impulsive. You could be more prone to anger, engage in more risky behaviors. These are all things that have psychological ramifications. And if you don't know a little bit about the medical side and the psychological side, then you're really treating these service members who are living with TBI sort of in a vacuum. And, that's to the detriment of the service member. Here's another gentleman, Dr. Saldana, who's also from Arizona State University. He argues that there's 32 categories for coding qualitative research, and here they are. Well, because I only had 18 months to 24 months to complete this research, I only used 3 different types of coding. First, I used in vivo coding. In vivo coding was just all it is simply an exercise of extracting a salient quote from a research participant that captures an answer to my overall research question. So if I heard something that I thought was really salient to what I was trying to get after, all I did was take the quote and I just put it in the final product. And I thought that really honored their voice, and I think it answered the research question. And that's a way to sort of mitigate against interpreting through my flawed filters what they were saying. Secondly, I used values coding. So in the Army, there's 7 values. I won't go through them all, but they can be memorized by the acronym leadership. And the S in Army stands for selfless service. But as a clinician, we always preach the importance of self-care. So selfless service and self-care might be an intra-value conflict. And sometimes that was acting as a barrier per se to treatment completion. And thirdly and finally, I used emotions coding. And anytime I saw or felt that the veteran was saying something with a lot of emotion, with anger or with tears, I thought that should be included because that was really getting into the internal emotional state of the person that I thought should be included in the final product. All right, so here are the sort of categories of results. Um, and I'll be mindful of time here. Uh, Not surprisingly, stigma was very high. Seeking mental health services in American society is very high. I think we're getting into a better we're getting better. Um, but I would argue that in the U.S. military and in the Army, stigma is probably even higher than civilian culture. So there was a lot of um, service members that I spoke with that they knew that they could probably benefit from seeking out mental health services, but they just didn't want to because of the stigma. I talked a little bit about intra-value conflicts. The soldiers that I talked to, they really value selfless service, so they would put themselves behind the team. You know, there's no individual culture; it's more of a collectivist culture in the Army. So it's more of a team sort of emphasis, and the mission is placed first. So I mean, when you go to war, you're willing to put your life on the line to complete a or achieve a certain mission. So, getting soldiers in a time of war to talk about their feelings is really kind of a hard thing to do as clinicians. Um, Another one is lack of privacy, and this seemed especially true for the younger enlisted soldiers who didn't enjoy some of the benefits that come with higher ranks. So one of the research participants that I talked to, he was a senior enlisted soldier, and he simply said, I would just tell people that I'm going to an appointment. I didn't have to disclose that I was going to a psychotherapy session. But if you're a private, you have to check in with your team leader, who could be a sergeant. That sergeant might check in with a squad leader, who's a staff sergeant. That staff sergeant might check in with the platoon sergeant, who's a sergeant first class. That person might check in with the platoon leader, who's a lieutenant. So you have 4 or 5 people that are going to be, that are going to know that this private is going to an appointment. And usually, privates can't just go up and leave because they'll disappear. So they have to know, okay, what kind of appointment? Why are you scheduling an appointment in the middle of the day? So just to sort of avoid all this, there were some privates that I spoke to that they said, I just don't do it. I just won't go because again, the stigma and the shame and the embarrassment of seeking mental health services is really viewed still as a sign of weakness. I'm not going to have time to go through all of these, so I'll just dabble with a couple that I think are important. Um, One was interpersonal barriers. I thought were pretty prominent. All the research participants said something uh, that could be characterized as an interpersonal barrier. One participant said that the clinician couldn't even look at him in the eyes when he was speaking, and he viewed this as a sign of disrespect, which is huge in the Army culture. Another one said that the clinician was sort of a yes man, and they would just apply these thick layers of support and empathy onto him, and he viewed this as sort of not helpful. He viewed this as a sort of a way to maintain his behavior, to maintain the psychological status quo, which was impairing his daily functioning. And he said it wasn't working for him, so he just dropped out. There's other things, intrapersonal barriers. That just refers to things inside the veteran that they feel like things that they feel that are a barrier to help seeking behaviors. There was one veteran who went to a lobby of a VA, and he was sitting next to another veteran who was clearly and actively psychotic. He was attending things that were not there. He was very agitated. And then the veteran that I spoke with internalized this notion or idea that the severity of his symptoms were just like the person who may had schizophrenia or something like that. And he said, wow, this guy, and he referred to him as crazy, is talking to people who are not here, and now I'm just like him. So that made him feel sort of negative about himself. And then he did some more processing and reflection on this. And then he realized, okay, I don't have schizophrenia, but I shouldn't be wasting the time of these clinicians because they're already overworked, they're already burnt out. And if I seek mental health services, I'm taking away time from my fellow veteran who probably needs it more than me. So that would be an example of an intrapersonal barrier, something that they believe, a cognition that they have that is preventing them from seeking mental health services. Um, I'll be happy to take any questions about any one of these other results that you see here, but in the interest of time, I'll just move on to some recommendations and then we'll wrap up. One of the things I recommend in chapter 5 is just having a conversation about mental health services to reduce the stigma. So I think having conversations like this are very important. May is Mental Health Awareness Month, and I think that um, once we can all sort of admit that as human beings, we will all at some point of our life, um, believe it or not, meet the diagnostic criteria for a mental health disorder. Two of the most common ones are depression or major depressive um, episodes and generalized anxiety disorder or another anxiety disorder, maybe an unspecified one. But these are more common than we probably most of us would like to admit. But I think having conversations like this are part of reducing the stigma. And I think it's important that we continue these conversations. Um, a lack of confidentiality and privacy was another reason. Um, you have even less confidentiality and privacy in the Army when compared to civilian clients. So I think it's important as clinicians, and you don't have to be a psychologist or a mental health care worker. You could be a nurse, you could be anybody else in the healthcare field. I think it's important that we sort of reaffirm and remind our patients that, you know, excuse me, this is personal information. I'm not going around talking to, my colleagues about why you're here. I'm just here to help you. And perceived political differences was another one. And in this context, you might, not be shocked to know that gun culture in the Army is very common and it's big. And I think clinicians, we could all probably be a little bit more comfortable talking to patients or clients about suicidal ideations if they are present. In Florida, clinicians, police officers, and others have the power to compel a patient to enter into inpatient therapy if they are to be deemed a threat to themselves or others. This power is colloquially referred to as the Baker Act. Unfortunately, I've seen, excuse me, in my own personal experience, a lot of people are sort of forced into these inpatient psychiatric care units, and it probably wasn't necessary. So if a client or a patient is revealing that they have passive suicidal ideations, that's not grounds for an inpatient psychiatric service. Uh, there are other elements that are necessary. It needs to take more of an act. The SI, the suicidal ideations, need to take more of an active presence. They need to have a plan. They need to have intent. They need to have access to their lethal means. But passive suicidal ideations is very common, and I think it would behoove clinicians to be a little bit more comfortable of what really um, would require the enforcement of a Baker Act. So those are just a few recommendations that I have. I also wanted to say in conclusion that as an adjunct faculty member of Keiser and as a veteran, I've personally felt that KU really honors and respects the sacrifices of our nation's members. And I've really enjoyed teaching psychology at the Fort Lauderdale campus of Keiser. I've had the privilege of already teaching a lot of students with a veteran status, and I find it to be very fulfilling work. And I just wanted to mention that the Keiser culture that I've seen, at least at Fort Lauderdale, really honors veterans, and that's something that I personally felt. All right, so with that being said, that concludes um, my presentation. So I'll stop sharing. If there's any questions, I'd be more than happy to answer any.
Major Harris, I have a question.
Yes, Mother. Thank you for being here.
I just want to, I thought you did a great job, son. Anyway, I used to work for Kaiser. I was the nursing program director at Fort Myers. It is a great university, and I'm a professor at another university. But I do have a question. Um, as a nurse, we are trained to understand shared life experience between our patients that we serve. We try to meet them what we call in between. We call that alternating rhythms. So, keeping that in mind, do you have recommendations for nurses to build trust between the caring nurse and the combat veteran?
Mom, thanks. You put me on the spot. I wish you gave this question to me in writing beforehand. We could have rehearsed this, but let's see. Okay. You can still hear me, right? I had something pop up. Okay. Yeah, meeting in between. Let's say a nurse who's treating a patient of theirs who happens to be a veteran, and the nurse does not have a veteran status. The research participants that I spoke to, I asked them a question that is pertaining to this, and I said, "Would you be open to working with a healthcare provider who doesn't have a veteran status?" And they said, "Yeah, I have no problem working with somebody who doesn't have a veteran status." Um, but one person said, "Don't act like you are an sort of expert on the culture." They had more sort of respect for the person who was actually curious and was asking questions about it, not acting like some sort of an expert, but just being genuinely curious and asking questions and not being sort of afraid to show their own ignorance and not to feign being some sort of expert on their culture. That could be seen through by anybody, and that's sort of presumptuous. But what nurses or psychologists can do, I think, in my experience, with that humility and saying, okay, I don't know what it's like to wear the uniform, for example, but I am trained, and I've in nurses, and I know because I was a little boy when you started nursing school. So I know how much training nurses have to undergo, and you are an expert in helping them with their needs. You are an expert at helping them deal with the presenting problem or deal with this reason for referral. And yeah, so I think that's one way where you can sort of meet them in between. Yeah, I didn't wear the uniform, but I know a little thing or two over here. So if you just meet me, I'll trust you, you trust me. I think that humility coupled with that expertise that you have as a nurse is could be an effective approach.
Thank you. We call that the dance of the caring person. Thank you very much.
And I think Justice Graves.
Yes. Hi. I don't have a camera, so
Okay.
I have a question. Did you consider for your qualitative study to do an audio ethnographic approach, and why or why not?
Yes, I did think about that. Are you familiar with ethnography?
Yes, I am. I'm currently working on a dissertation as well, and my
Oh,
dissertation is also qualitative, and I also chose in vitro coding style from the same
oh,
author.
oh.
And I chose not to do that approach because I didn't
Mhm,
fit my guidelines of my
mhm.
population study, but you fit your own guidelines of your study. So I was just curious.
Yeah. How many research participants do you anticipate having? Do you know yet?
I'm aiming between 9 and 15, but more than likely 8 to 12.
Yeah, that's a lot. Okay.
Yeah.
I did think about ethnography. I chose, and then there's lots of different sort of forms of qualitative research. You could do case studies. You could do things called grounded theory, ethnography. I chose a to assume a more phenomenological posture because, again, I was really interested when it came down to it in the internal phenomena that these combat veterans were experiencing during their psychotherapeutic session experience. So it really went back to this German philosophy of phenomenology. I was really influenced by Edmund Husserl, uh, who was sort of the father of a phenomenological approach. And as an aspiring clinical psychologist, I thought that this internal phenomena was sort of the heart of the matter. So I just chose a more phenomenological approach. I hope that answers your question.
Right, it does. I also have a different question, if that's
Yes,
okay to ask.
of course.
So the DSM-5, I'm assuming in your qualitative study, you had to outline the actual definition of PTSD, but the most recent one is from 2013, and typically when it comes to scientific data, you want to use within the past 5 years when it comes to definition. So how did you overcome that kind of distance year-wise?
Sure. Um, I used the DSM-5 TR. I think it was published in 2021 or 2022. So that would fall within the window of the 5 year gap that you're referring to, the 5 year window. But between the DSM-5 and the DSM-5 TR, if you look at PTSD, that didn't really change that much. Now there was a big difference between the DSM-4 and the DSM-5. PTSD used to be thought of as an anxiety disorder per se. Now the scientific research has demonstrated that putting PTSD or conceptualizing PTSD as an anxiety disorder per se doesn't capture other cognitive components to PTSD. So when somebody has PTSD, their view of themselves, other in the world, are just radically shifted. They're radically different. So people with PTSD that are internalizing things, they might say, like, I'm damaged goods. This happened to me, therefore I am damaged. Or they might think, the whole world is bad because, and it's filled with bad people in it that do these things to you. And that really is sort of, they generalize these cognitions based upon something in their personal experience that happens to them, and they sort of extrapolate or generalize to the whole world. So PTSD, again, that was between the 4 and the 5. Between the 5 and the text revision, I don't think it changed that much.
Awesome. Thank you so much.
Were there any other questions? I saw a hand up previously, but I might have missed you. Okay. Well, thank you. Thank you for attending. Thank you, Shoshana, for putting this
Yeah,
together and allowing me
thank
to
you.
share.
Thank you so much for this amazing presentation. You did a fantastic job. It was very interesting, and I'm glad you shared your work with us. Um, for all of you who attended, I hope that you were able to enjoy your lunch and enjoyed it while also enjoying this wonderful research study. And if you are interested in presenting as well, I'm including a link in the chat and also the link to the RSC if you are not already a member. And I hope that you all find your way there, and would love to hear from you all. And thank you again for presenting. Really appreciate it.
Thank you.
Bye,
Bye-bye.
guys.
Bye,
Have a great
Mom.
day.